Welcome to Pediatric Grand Rounds. Really excited today to introduce our speaker, Dr. Ted Miguel, who is visiting us today from UC Berkeley. Dr. Miguel is a professor of economics and co-director of the Center for Effective Global Action at UC Berkeley. He's an economist who studies African economic development and specifically examining the links between health, education, and productivity. And today he's going to share with us his work that comes out of his studies in Kenya on exploring how direct cash transfers can improve birth outcomes and health outcomes. So please join me in welcoming Dr. Miguel.
It's great to be here. Thanks so much for having me for the introduction, and really delighted to be able to present this work. I just want to start with a little bit of background. I'm an economist, as was mentioned. I focused on African economic development. When I started my graduate training in the 1990s, I was drawn to working in this region in sub-Saharan Africa for a bunch of different reasons, but mainly really it was the most challenging environment for those of us who wanted to focus on international development and also global health issues. Poorest region of the world, no matter how you measure it. Fast rates of population growth. There are very high rates of armed conflict then and still. And then in terms of health outcomes, the highest rates of infant mortality in the world, tropical disease, obviously HIV/AIDS as well. And as an economist, a development economist, really one of the questions that we've been interested in is, how much is all this due to a lack of resources? Clearly, there's a kind of bi-directional relationship between economic development and lots of these outcomes. But if we could only improve the amount of resources available, people's living standards, how much could we improve their lives? That was really the kind of question that we had in mind. But I want to give, again, a little more background than usual, just because I'm coming from a different field. When I started my graduate training in the 90s, economics was still coming out of a period where it was very model-driven, theory-driven. Economists had spent several decades developing really intricate mathematical models of how the economy worked, but it wasn't really very evidence-based or data-driven at that time. And in the 1980s and 1990s, that really changed with leadership, including by my colleague, recently retired at Berkeley, Dave Card, who won the Nobel Prize in economics, to really bring modern statistical tools and data to bear on economic issues. My own focus was to apply these tools and these approaches in low and middle income countries. And to do so, we faced even more kind of challenges than usual. The first one that we faced is we often had a real, extreme lack of data. Government statistical agencies in lots of African countries don't produce the kind of data series we get in places like the United States. So we had a lack of data on important variables. Obviously, in trying to understand the impacts of policy, there's a lot of potential confounding, omitted variables to contend with. And when I started working in Kenya in particular in graduate school, there was very limited research infrastructure there to carry out work. That's changed quite a bit. There's a lot more people with PhDs. There's more research institutes now than 30 years ago, but it still remains challenging in some ways. One of the big changes in terms of the methodology of our work, and this is one way in which we were inspired by work in public health and in medicine, is starting in the 1990s, we started to use randomized controlled trials in development economics. And in many ways, development economics is a natural place to apply RCTs. We were working with nonprofits and NGOs and governments that are often resource constrained. They can't help everybody in need. There's extreme poverty. And so with limited resources where you can't reach everybody, and only a subset of people are going to get assistance, randomized controlled trials in which some get assistance and some don't, some get economic programs, training, et cetera, and some don't, allow us to at least understand the effects of those programs and policies. I was part of an initial group of researchers in the mid to late 1990s that started applying RCTs in development economics, and I'll talk about an RCT today as well. We also have been pushing for more open science practices and research transparency in our work, pre-registering studies, and the level of collaboration with researchers from low and middle income countries has also really increased, and it's been a priority of our group, and really an attempt to carry out this research in an ethical way. So certainly in the Q&A, I'm very happy to talk about the methods we use and our approaches. I'm not going to get into all the details, obviously, in the main talk, but very happy to engage. Okay. So that's a little bit of background about like where I'm coming from and some of the links methodologically to what you're familiar with medical trials or clinical trials. But what I'm going to focus on today is a particular type of intervention, direct cash transfers to the poor, that have become very widespread in the policy space, very widespread in international development, and I'm going to study impacts on important health outcomes. So that's really the connection, in particular child health outcomes. Cash transfers are structured in a way that's very different than traditional foreign aid. Traditional foreign aid that you may be familiar with, where a bilateral donor, a multilateral donor, engages with the government around policy reform, institutional reform. We're going to, let's say the World Bank is going to propose changing the tax system in Kenya or, trade policy in Nigeria. That's, and in sort of exchange for those policy changes, foreign aid is given. There's that kind of structural adjustment approach you may be familiar with. Cash transfers are like the polar opposite approach. Cash transfers are typically given directly to households rather than to governments. They go in people's pockets directly, and very often they're given unconditionally. Now, there's different types of cash transfers. Some are conditional. I'm going to be talking about unconditional cash transfers today. What basically an NGO or a government needs to do is identify the poor, identify a population that is in need, and then find a way to give them money and let them do what they will with money. So kind of very big departure from traditional foreign aid. They become very common. Tons of countries now have direct cash transfer programs. They became even more common during the pandemic. But a lot of those programs have actually remained in place even after the pandemic. So, like 1 billion, 2 billion people, 1 to 2 billion a year will be receiving cash transfers these days. We're going to try to understand what cash transfers do, but closely related, in our mind here is we're going to try to understand whether cash transfers are enough or whether other types of assistance, other types of public goods, other types of public investments are needed to yield health gains in a context where cash transfers are going out. So just keep that in mind. You might say like the most basic thing you'd have in mind is, well, if I give people cash transfers and I'm interested in improving child health, but there's like no clinics or hospitals around in this part of rural Kenya, like how much benefit are we really going to have? Maybe we'll have some, maybe certain outcomes will improve. Maybe we'll have more if we get that complementarity between cash and a sort of public investment. So just keep that in mind because it's going to kind of figure in to some of the analysis. Okay, so what's the intervention? We studied, starting about a decade ago, I began working with my research team in Berkeley and in Kenya with an NGO called Give Directly. So people may have heard of them. They've really grown a lot in the last decade. They were kind of a smallish NGO at this time. Now they're giving out hundreds of millions of dollars a year in direct cash transfers in dozens of countries around the world. They try to identify poor households and transfer money to them via cell phone, via mobile money. And the reason they do that is, the overhead associated with transferring money versus via cell phone is low. They basically identify poor areas, poor villages, poor households, transfer money to them by cell phone, and then that's it. There's no real monitoring. They basically, their ideology or their approach is to say, look, we trust poor households to do what's best for them. Maybe some households want to, pay for more education. Others want to buy more food. Others want to build a new roof, whatever they want to do. So that's really their mentality. What's also really notable about their intervention is they're very large transfers. So at the time this cash transfer was going out, it was $1,000 in kind of nominal terms. So, because prices are lower in East Africa, that's like worth even more, in terms of our prices. That was about 3/4 of average household income. So, the equivalent in the US would be giving a poor household, I don't know, $10,000 or $20,000. So this is like a really big cash transfer. It's a one-time transfer. You only get it, you're enrolled in the program, you get the $1,000. They give it to you over 3 tranches, so over a period of 8 months. Once those tranches are done, you're out of the program. But the idea is maybe this unlocks new opportunities for households and new possibilities. We worked with Give Directly to raise money, and we ended up helping them raise $11 million for this study. Because they kind of went to their donors saying, hey, we have this big group of researchers that are really going to study the impact of these cash transfers in a large scale way. So I'll tell you, this was quite a large scale evaluation. So pretty exciting for us to be involved in a study that large where 11,000 households received cash transfers. The total study population I'll be talking about is about 65,000 households, and we surveyed all of them. So, pretty large scale data collection. exercise. They targeted money. Let me just say one more thing here. They targeted money to poor households in rural Kenya at this point in time using a very low-cost proxy for poverty. They looked for households in rural Kenya that had a grass-thatched roof rather than a metal roof. You may say, how does that work? Well, it turns out at this period of time in rural East Africa, somewhat richer households had improved housing structures. Ceramic roofs, metal roofs. The poor households tended to have grass-thatched roofs. We confirmed that in the data. The households with grass-thatched roofs have roughly half the wealth compared to the households with metal roofs. They're about, the metal roof households are like twice as rich. So it's not a bad first proxy to target the poor. Again, part of the reason they use a simple proxy is they want to limit their overhead. They don't want to be doing tons of data collection just to identify the poor. They do a quick and dirty approach, and then they transfer money to them. What we ended up doing is partnering with multiple different Kenyan organizations, of course, with approvals from Kenyan government and IRB, et cetera, to carry out a large-scale data collection to study the impact of this program. This is just a picture of me in the field. Typically, when data collection is going on, I'm not there. Foreigners, aren't there, but this is just a shot of data collection. Surveys are carried out actually on tablets these days. And we had to collect our own data because of one of the challenges I mentioned up front. There's really limited government economic data and health data that we could use to understand the impacts of these cash transfers. We had to design our own household surveys, enterprise surveys. We surveyed local clinics to get the data that we needed for this study. In all, we censused these 65,000 households in the area, 10,000 private enterprises. And we had a big team of 80 or so enumerators plus some managers based in Kenya, a big team of researchers also based in Berkeley. And here are the partners that we worked with. All right, so I want to start with just 2 or 3 minutes on the economic impacts, because they're going to kind of set the stage for the health impacts of the study. So why could cash transfers matter? It's kind of obvious that if you give a poor household cash, it may benefit them directly. They were poor, now they can buy food, now they can buy other things. And a bunch of earlier studies had documented that. There have been RCTs, individual household level RCTs that had documented the sort of living standards improvement for households that got large cash transfer. What we were interested in, and I'll talk about the research design that allows us to get at this, is the broader economic effects and then broader health effects of the program. It turns out when people get their money on their cell phones, they get mobile money. We collect data to try to understand how they use it, how they spend it. And they tend, in poor households in rural Kenya, they tend to spend it very quickly. So what economists call the marginal propensity to consume. For every dollar you get, what percent do you spend, say, within the first year, is very high in these households. 80 to 90%. Very little of it is being saved. So if you're a poor rural household, you have a lot of desperate needs, you get money, you basically spend it right away. But what that means is local businesses, local firms, local enterprises are benefiting because most of that spending is really in local businesses. So their revenue is going up, their profits may be going up, their workers may have more work to do, so their wages would go up. So that's the beginning of the kind of spillover effects of the program. What we could then do is try to study what these shop owners and workers do themselves. Are they able to spend more money? Are their living standards improved because there's more money circulating in income? Okay, so that was the kind of economic question, which will set the stage for the health impacts. Now, how do we measure these spillover effects and these multiplier effects? We had to use a bit of a different design for our RCT than your standard individual level, patient level design. And this is something that actually in our work as economists, we've been trying to advance. Ben knows about this because we talked about this a lot and even worked on this a long time ago, to try to understand spillover effects, externalities. So, what we would ideally like to have to study the effect on a whole economy of cash transfers is say, hey, here's an economy in blue where lots of cash transfers are going in, and we want to understand what happens to households and enterprises and how in this whole system, what type of equilibrium do we get to, and compare that economy to the yellow economies where there were no cash transfers going on. That would be the ideal. Now, it's been hard to estimate these things in practice. There are some estimates of what multiplier effects of cash transfers look like, say, in the US, following the stimulus checks people got during the Great Recession. But those went out across the whole country. So we don't have a great counterfactual. If you're thinking in terms of experimental design, you have to make a lot of assumptions to try to understand the effect of those stimulus checks, right? Everybody got them, around the country. So, what do? We might start with a very simple household level randomization. Some households get cash, some don't. But that's not really going to work. If these are neighboring households, there's interference. They're affecting each other. Me getting cash could affect the business of my neighbor, etc. So that design isn't going to work very well. The kind of design that we used here, and I'm just showing it schematically, very happy in the Q&A to get into more of the statistics and the regression design, is we had a multi-level randomization. There were certain sub-areas of our study region where a lot of cash went out to poor households. Think of that as the high treatment region here in blue, and other regions, the yellow region, where not that much cash went out. But even in the high treatment regions, in the randomization, there were some villages that were controlled. Again, we're working in a setting where there's a lot of need and limited funding, so we're basically spending every dollar we can spend on cash transfers. We're just kind of allocating it with a particular design. The yellow household in the blue region is really interesting for us because here we can understand if I don't get cash, but I'm in an area where lots of households are getting cash, what is the spillover benefit to me? Similarly, in the low treatment region, there are some villages and households that do get cash because there we can isolate the effect of me getting cash alone without anybody around me getting cash. So actually, this kind of design where you have a multi-level randomization allows us to get at some of the parameters we care about in terms of policy. What's the direct effect? What's the spillover effect? How do they add up? So that was the design. We implement this in a region of rural Western Kenya called Siaya County, where there are sub-locations, about 68 sub-locations, some randomized into this high treatment area, some into the low treatment area, but with that two-level randomization, where there's still some variation in treatment status, even within those areas. So this kind of design allows us to kind of add up the direct effect and the spillover effect, whether it's the economic impact or the health impact, right? So that's the kind of starting point for the design. We were only able to do this because we're working in an area with 300,000 people. We surveyed the 65,000 households. We were really fortunate to get a lot of research money to do this and have a really big team. And that just gives us, 68 of these little sub-location local economies, each with around a dozen villages, to study localized economic effects and health effects. All right, let me get to results. Briefly, economic impacts, and then the focus today, health impacts. What did we find in the first study we published here? It turns out that in addition to the direct effects for recipients of getting cash transfers, there are big economic spillover effects. For every dollar that goes into one of these high treatment regions, economic incomes, if you think of sort of economic activity, increases by $2.5. That first dollar and another $1.50. And actually, in terms of economic theory, this makes perfect sense because the marginal propensity to consume is so high. People get money, they spend it. So local businesses get more business. They hire more employees, et cetera. There's this kind of spillover effect in the economy. And you might be concerned that when you throw a lot of cash into an economy, it would lead to a lot of price inflation. That's something on people's minds here. We did price surveys in every market in this whole area every month for 3 years. We collected data on 70 different items in all those markets. There is some price inflation in the high treatment areas, but it's small. So the real gain in terms of real incomes is 2.4 rather than 2.5. It's very, very much the same. People are also concerned that maybe if you give poor people cash transfers, they'll stop working. They're concerned they'll waste the money on sinful things. Based on all of our measurements, poor people really use the vast majority of the money to meet their basic needs. There was no disemployment effect. People worked just as much before and after getting the cash. So pretty interesting set of results. And the reason this study has gotten attention in economics, I know it's of less interest here in global health, is we have a large-scale experimental RCT-based evidence on these spillovers, which had only been kind of estimated by macroeconomists with country-level analysis. So this is a kind of more methodologically sound approach. Okay, that's the end of the economics. Now we're going to get to the global health part, and I know that's why you guys are here. But thanks for staying with me through the economics. This is actually going to matter because we're going to try to understand what's going on with global health. We have to understand how people's incomes were changing. Well, their incomes increased a lot. So the new study, and this is a new work, we call it working papers. I think usually people call it maybe preprints in public health. This is a new paper recently submitted trying to understand the effects of the exact same program on child health. So what happened in these areas when these massive cash transfers went out? And this is just my schematic. Again, the mobile money is distributed, in this case, to someone who's expecting a child. How does this change their life? It could affect the child's outcomes in many ways. Remember before I was talking about, how does local health infrastructure potentially matter when I get cash? Well, when I get a cash transfer, maybe now I can actually purchase transportation, which allows me to get to the clinic. Maybe I have money in hand to access and pay for healthcare. Officially in Kenya, delivery services are meant to be free or close to free. And for certain rural clinics, there are government subsidies that make them close to free. But for hospitals and facilities that have physicians and facilities that have really better delivery services, you typically have to pay quite a bit of money in rural Kenya. And that's based on our surveys and also based on other evidence in this area. So you may need to pay $60, $80 to deliver in a hospital, which for poor households is a lot of money. Women are expected in those hospitals to bring their own birthing kit with the materials they may need if there are complications. So it's really something that could be out of reach for poor households. So having money in hand could matter. You might also think that having money in hand could change other things. When people have money in hand, they may eat more. When people have money in hand when they're about to deliver, maybe they can, take time off from work and not work right up until the day of delivery, et cetera. So again, getting a big cash transfer could affect a lot of decisions. We put in place surveys 2 years ago where we asked households to recall their births over the previous decade, all the details they could recall, and very detailed information on birth outcomes. So what did we do? We, as I mentioned, two years ago, censused all these households again. We were very happy with the follow-up rate. We got a 92% survey follow-up rate. Really delighted with that. We followed the households that moved. About 5% of households had migrated. We sent our teams, if they had moved 100, 200 miles away to Nairobi, we surveyed them. We wanted to make sure we got their birth histories as well. And, across these 60,000 households, we asked about births in this time period, and we got data on over 100,000 births. So this is a big data set. There had been interest in this question of how child health outcomes change when cash transfers go out in East Africa and other parts of Africa before, typically based on data from small-scale RCTs. An RCT with maybe 500 households getting a cash transfer. They just didn't have the sample size to be powered up to detect effects. So I think fundamentally to this room, if you're thinking about what's different methodologically about this study, it's the scale of the study, and we have enough sample to say things with some precision here. So we collected data on birth histories and child survival. An average infant mortality and under 5 mortality is pretty close to the Kenyan national average, as it turns out. So that's maybe reassuring. When there was a death, we collected data from a mother, a father, another adult in the household. We collected verbal autopsy data, trying to understand the cause of death. There's no complete vital statistics records in rural Kenya. Autopsies aren't done on deaths. We don't have official data on the cause of death. Verbal autopsy is carried out in cases like this, where there are really screener questions around the broad causes of death, and then was it an accident? Did they have a fever? Did they have a cough? And then following those screener questions, they get deeper and deeper to try to understand the cause of death. The World Health Organization has developed different versions of these verbal autopsies. The Kenya Medical Research Institute, we were very lucky, just a year before our study, had been testing verbal autopsies in Western Kenya, right around where we were working, and had basically taken training data, like proper autopsy data, linked it to the surveys, and used machine learning algorithms as prediction models to try to predict cause of death. So we're just able to use an algorithm that had been developed like a year earlier in this part of Kenya. We were really lucky. And we had the people who've been working on it at Kemry train our team. So we were able to administer the verbal autopsy as, I think appropriately. It's a very sensitive set of questions. Obviously, we're talking about a child that had died several years earlier or a year earlier. In about 17% of cases, the parents didn't want to talk about it. And that's great. That's fine. That's their right. But again, all the enumerators, the surveyors are Kenyan. They were trained by KEMRI to be sensitive and try to encourage people to share any information they could. And about 83% of the time, we were able to get the verbal autopsy data. Okay, so what do we find? About 20 minutes in, and this is sort of now, I'm finally getting to some results. So what do we find? I'm going to show you data across 3 different groups. Let me start with red. Red is the average infant mortality, under 1 mortality per 1,000 births in the control villages in those low treatment regions. This is the closest thing we have to a pure control. They didn't get cash themselves. These are poor households, but they didn't get cash, and few of their neighbors got cash. That's the red. And I'm going to show you also the blue, which is going to be the treated poor households in the high treatment regions. So I got cash and everybody around me got cash. That's like our strongest treatment. So that contrast in the research design is kind of our strongest contrast. And then I'll talk about the ineligibles later in yellow. The ineligibles are the people with the metal roofs. Those are the people that are like twice as rich on average. I'll show you their data in a second. And I'll show you data for 3 time points. The period before the transfers, cash transfers went out, the period when they were going out, and then the post-transfer period. Okay, so what does the data look like? For the control group, the average infant mortality, and this is again, 2011 to around 2017, is like 35 to 40 deaths per 1,000. So again, pretty close to the Kenyan national average. What does it look like in treatment areas? So in the pre-transfer period, the blue and the red are very close. And actually, you can see the gray bars. That's the confidence interval, 95% confidence interval on the difference between those 2 things. So since the red dot lies there, it means they're not statistically significant, the difference there. One is 39 and one is 35 or something like that. So they're balanced at baseline. But in the period where the cash transfers get out, there's a drop of between 45 to 50% in infant mortality. So we started collecting this data, and we're kind of getting rounds and rounds of data, and this is the main finding of the paper right here. That difference is significant at 99% confidence. We even do multiple hypothesis testing corrections, et cetera. It's still significant at even 95% confidence there, and huge effect. So this is like the central finding of the paper. When cash went out, infant mortality dropped a lot in this setting. Okay. What happened when the cash ends? What happens in the post-transfer period? Maybe ask yourself, do the gaps remain? Do they close? What do we think happens? I won't ask you to say it out loud, but think inside, in your head, it turns out the groups just kind of converge back to normal. When the cash is going out, birth outcomes are better in the treatment group. The cash ends, they're basically back to where they were before, no significant difference between the 2. Now, when I presented this figure, sometimes people said, well, there really aren't persistent effects. This is kind of disappointing. I can see why people say that. My answer to that is, well, there really are persistent effects because all these kids are now alive who were born in that one period. So that's where there are kind of persistent gains. But it is true that when the cash ends, birth outcomes kind of go back to where they were before. All right. What about the yellow group? These are the richer households. What do they look like? This is a pretty interesting contrast. If you look here, the yellow line is pretty parallel to the red line. Maybe a little difference in slope. Pretty parallel to the red line. Definitely lower than the red line. Instead of around 40 deaths, there's around 30 deaths per 1,000. Again, they're richer. And so what's kind of nice about this is the cross-sectional relationship between rich and poor households looks kind of similar to the experimental relationship when cash goes out. So it feels sort of fundamental. Richer households are doing better. Their kids survive more. Whether we look in the cross-section, yellow versus red, or with the experimental variation, the red versus the blue. All right, that's the main finding. And now the next few slides are just data and figures to help us understand what's going on. And this is the verbal autopsy data. So for the 83% of cases where we could get the data, we can try to figure out the cause of death based on this machine learning algorithm. The total drop in deaths per 1,000 was around 19. I kind of showed you that in the previous figure, from 40 to 20, roughly. The 2 main causes of death in this population, each around 35 to 40% of deaths, are maternal or neonatal causes, delivery complications, deaths shortly after birth, and communicable or respiratory diseases. So really infectious diseases. There's a lot of malaria, But there's also upper respiratory infections, smaller numbers of non-communicable diseases, injuries. They're there and they come out of the verbal autopsy, but they're smaller. These are the two main causes. It turns out the largest reduction is in maternal and neonatal causes, delivery-related complications. Causes where maybe access to better antenatal care and delivery services could make a difference here. There's not so much in the other causes. A small reduction in communicable or respiratory deaths, but not very large. And then on the right-hand side, you see that minus 3.98. Those are the cases with no verbal autopsy, no VA, where the parent didn't want to respond. So that is also a share of the total number. If the proportions for the causes of death apply to the no VA case, which we don't know is true, but if it did, about 2/3 of the reduction overall would come from maternal neonatal. Okay. So that's another kind of fact. Let me show you one other fact from the data, and then get into some other explanation. The other thing that we have in our data is the timing of when the cash went out. So this NGO, Give Directly, worked with us. They said, look, we're going to give cash out in these areas. We worked with them on the randomization. All this analysis, by the way, I should say, is independent of Give Directly. We're an independent team. We got separate research funding. But we did work with them on the design. And what we work with them on is a design in which different villages were brought into the cash transfers in random order. We really didn't want that to be systematic because it could lead to bias. And so people in certain villages didn't know when they were going to get phased into the program. Give Directly showed up and said, okay, next month you're going to get the cash transfer. So we have variation in timing of when the cash transfer went out relative to when women are pregnant here. What do we find? When the cash transfer goes out and people are receiving the cash before the birth month, so before they were even pregnant or when the child is in utero, there are pretty substantial reductions in infant mortality, a reduction of 12 or 13 on a base of 40. That's actually really big. Marginally significant, kind of statistically significant on its own. The really big effect, though, is for people getting cash in the birth month. So this is really what's driving the effect. If you're getting cash in the birth month, there's a reduction of infant mortality in the sample down to like US levels, basically. Huge reduction in infant mortality of like 39 per thousand. This is quite a striking finding, which again is kind of consistent with the view that maybe access to good delivery services matters a lot. Because if you have cash in hand at that moment, your child does much better. People who get the cash when their child is already born, there's no effect on their child mortality. Now we do know, like if you look at the 1+, the vast majority of the under 5 mortality is coming through in the first year of life. Actually, there's much less in years 1 to 5. So there's sort of almost less to explain there. But still pretty striking pattern. Getting it before helps, especially if you have cash in hand at the birth month. And what I mean cash in hand is, remember I told you get the 3 tranches of cash from Give Directly over 8 months? It basically means the birth month is like in that window. That's how we define it. Right. So what could explain these effects? We carried out detailed household surveys. We asked women about their behaviors. We asked them about hospital deliveries. We asked them about how much they worked, other things. And we found these really striking patterns. Again, I've been working in this field for a long time. I have lots of papers with precise null effects. I have lots of papers where we find things that just don't make sense to us. We're not smart enough to figure out what's going on. This happens to be a study where things line up with like a pretty straightforward explanation for what's going on. So what do we find? We find that if you're getting the cash transfer, there's a huge increase in hospital deliveries. You can actually pay to go to these better hospitals that have doctors, that have trained nurses, that have better delivery services. We find something else, and this is, economists are very interested in this. It turns out that the women who are getting cash transfers in the 3rd trimester of pregnancy have big reductions in labor supply. When we ask them, how many hours did you work in the last week? Women in the control group in the 3rd trimester, on average, in rural Kenya, are working 36 hours per week. Typically in subsistence farming or in small retail. They're working really hard, like right up until the baby's born. because they're very poor. They need to work. When cash transfers go out, their labor supply falls by like 18 hours in the third trimester. So in that potentially difficult period where there could be, they may need access they may need to go in for antenatal care. There may be complications. They may find it very difficult to work if they're, 40 weeks pregnant. They're able to step back from it during that period. I will say that after the delivery and after the child's born, their work goes right back up to where it was in the control group. So it's not like they're permanently out of labor. Finally, various measures of nutrition and food consumption also increase among both mothers and children. More meals eaten, more food purchased, less reported food insecurity. All of these things could be contributing to better birth outcomes for kids. Obviously, delivery services, etc. One last bit of data. I've been throwing a lot of figures at you, and I'll kind of go to a broader discussion. We find two dimensions of heterogeneity that are pretty interesting. And again, we're able to look at subgroups with decent statistical power here because we've got this big sample size. Again, I think other studies would struggle to do this. Two things I'm going to mention. I'll show you one in the figure. I'll just mention the first in a bullet. Households that live closer to facilities with doctors show larger gains from transfer. That's what we're finding. Again, it gets back to this story that cash alone may not be enough. You may need to be able to access healthcare services. But if you can, they're really big gains. The second one has to do with poverty. We have baseline data on household assets, their wealth. There's a lot of variation across households and wealth. We divide them into above median, below median. So rich or poor, just based on measured assets. That could be cattle, livestock, household goods, assets, a bicycle, a motorcycle, financial assets, bank account, etc. The effect on infant mortality for the richer households is just zero in our sample. The whole effect is being driven by the poor households. So again, there's just a story to kind of sum it up where the poorest households in rural Kenya are really poor. And money goes a long way for them in allowing them to access healthcare services, take time off from work in critical moments, have improved nutrition. I can't tell you how much each of those mechanisms contribute to the effect without much stronger statistical assumptions, but some combination of those factors seem to be really key in driving the effects for poor households. Okay, so I'll just wrap up with a little bit more data, and then I think we'll have time for discussion. So how many deaths did the transfers prevent based on the analysis? Here I'm going to talk about the under 5 effect. Most of the reduction was in under 1, it was like 19. But if you look at the under 5 mortality effect, if we compare that high treatment group in the high treated areas to the closest thing to the pure control group, it's a reduction of about 24 deaths per 1,000, under 5 deaths, really big effect, significant at 99%. Confidence, if we look at the births in that high treatment area in the correct window, there were several thousand of that. If I just multiply these things together, the implied number of lives saved is 86. 86 kids lived to age 5 because of the cash transfers just in this one county of Kenya. Of course, for those of us as researchers, to know that we helped to raise the money for this study and distribute it is like an incredibly gratifying thing to be part of. Here, we could just leave it here and say, okay, this is the value, 86 lives saved. That's probably the most natural thing to do. There are attempts in health economics and in global health to try to put things in sort of money metric units. People may be familiar with DALYs, disability adjusted life years. And these are very controversial. Economists use certain numbers, other people use others. I'm not going to take a stand on what the right number is. I'm just going to show a number that's used by a large donor. This is GiveWell, not Give Directly. GiveWell is a foreign aid donor group that raises money and distributes it a lot in global health, actually. And in their own decision making, they try to weigh, the value of spending in different countries. So they basically have a formula where they scale, the value of a death averted, effectively based on income. That's what they do. So in richer countries, they weigh more than in poor countries. So it's like what people call value of statistical life. Very controversial. I'm not going to say this is right or wrong. This is just a number that's used by certain policymakers. If we use their number, the dollar value of these lives saved, if we want to do that, is pretty large. Remember, we gave out 11 million. They Give Directly gave out $11 million to start. Like, just these lives saved almost justify that spending, and that's not even taking into account all the economic benefits that we also measure with the other work. So again, I'm not saying this is the right number or the wrong number, other than to say if we do try to put a value on the lives saved, it's really large. And maybe this number is too low, and then the 7.6 could be twice as high, just depending on the number we choose. All right, so let me just wrap up so we have time for questions. Cash transfers led to a lot of lives being saved in rural Kenya. That's, the $7.6 million is one way to think about cost effectiveness. Another way would be to imagine redesigning the program just to target the cash transfers to pregnant women in the third trimester. Remember, I showed you there's like a really big reduction, like women who are about to give birth have the money in hand. There's a huge reduction. If you could cost effectively target those women, the cost per life saved would be relatively low. I mean, there's, again, different standards the WHO uses and others for what's a cost effective investment, but this number would get in that group of at least relatively cost effective investments to avoid child death. And the punchline, I think, for policy, and this is, I think, important for people interested in cash transfers, but also in sort of public health policy, cash alone may not be enough. We found much bigger effects for cash targeted to pregnant women, for cash targeted to areas where there are clinics available, for cash targeted to the poorest households. But if you can target those households, this could be a very cost-effective way, not just to improve living standards, which has been shown, but actually to save lives as well. And I'll just close with like one word for all of us doing international work. This has been such a challenging year for everybody doing international development work, global health work. So many programs have been shuttered. And the center that I co-direct, Center for Effective Global Action, is based at Berkeley, but actually has faculty affiliates in campuses up and down the West Coast. And I just want to say that, like, for those interested in these topics, we're really eager to collaborate with folks at UCSF or elsewhere doing work. It's kind of a moment where more than ever we need to collaborate, work together, because the challenges for global health and international development were already really daunting, and then with the all the aid cuts and changes in policy, even more so. So just want to put that out there that we're really eager to collaborate in this kind of work going forward. And yeah, I'm happy to open up for questions if folks have.
Maybe I'll start. That was really great. Thank you. Do you have any data, or if you don't have data, would you care to hypothesize whether you would see similar findings in urban areas?
Yeah, so we don't have data. Incomes in urban areas in Kenya are far higher on average than rural areas. And so if I were to kind of just take this number seriously, the poverty number, that would make, indicate, well, maybe effects would be lower there. The flip side is there's a lot better access to healthcare facilities in urban areas. So I'm not sure. The two kind of dimensions of heterogeneity that we have cut in different directions for urban areas. So people are richer, they may gain less, but they can access the healthcare services. I'm not sure. So in general, the economic benefits could be quite different because there's a lot higher density of markets in urban areas, and again, different density of public facilities. Yeah, I'm not going to kind of go on the record hypothesizing on it, but it could go either way. I don't think our data is super clear.
I'm actually watching the Zoom here, and you have a robust audience.
Oh, great! I look forward to
a lot of questions, so I'm try to get some of those in front of you. The first question is about whether there were any temporal effects related to any national programs to address maternal and neonatal death.
Yeah, so great question. Several years before we started, there was a program in Kenya called Linda Mama, which means like take care of mothers, and that was the program that reduced the cost of deliveries in public clinics, but only certain ones. But during the period we study, that had already been was being implemented or had been implemented mainly. And of course, the nice thing about a randomized controlled trial is any national level policy is kind of the same for treatment and control groups, of course, here, if there's any trends. But no, there wasn't any kind of massive change other than that program, which was already kind of being established at the start of the period.
And the next question is there a potential benefit with additional transfers for specific conditions which could place greater financial burdens on families, such as with HIV, TB, or malnutrition?
It could be. I think, that the notion that maybe households experiencing those conditions or with particular needs could benefit more is totally reasonable. We don't have that. We don't have that data. We don't have that data, basically. And especially in the full census, like a lot of the analysis is based, I didn't get into all the design issues. The main analysis is based on our census of all 65,000 households. Then among 8,000 to 9,000 households, representative households, we did very detailed surveys. So in terms of, a lot of the heterogeneity analysis is using the kind of full sample. We have better health data for that subset, the 8,000 households, but then we're kind of reaching sample size issues. So I'm not sure what we can say.
Were there any collateral effects, for example, effect on malaria?
We did look at self-reported health, but we only have relatively crude measures. And there are some improvements in general self-reported health in the treatment group. But we haven't focused as much on measurement of, say, adult health or health beyond the sort of child mortality. We are fundraising right now to try to do more on that, but we don't have that data. So, I think that those are great questions. I would say the rough answer would be like very crude measures of health would indicate they improved somewhat in the treatment group. Even some mental health measures improved as well, but we don't have sufficiently detailed data to know exactly what was changing.
Did they improve and then go back? Or did they improve and stay?
Yeah, they improved and then they went back. Some of the mental health gains you see, we've carried out a baseline survey and then 3 follow-ups. And in fact, we just finished the 3rd follow-up last year, so it's a 10-year follow-up, and we're hoping to continue. And what you see is some of the kind of stated health gains, physical health and mental health gains appear in the first follow-up and then diminish. In terms of the economic gains, in the very short run, of course, in the treatment households are these big consumption gains where they got this huge transfer. One of the things we're finding is even 10 years out, there are some persistent income and consumption gains, but they're much smaller. They're like 5 to 10% gains in consumption and income, which is pretty good, given that it's 10 years later. But a 5 to 10% income gain wouldn't necessarily generate really massive health changes. I saw Ben had a hand.
Just 2 quick design questions. This is so interesting. One was, can you just give us a sense? You mentioned high treatment intensity, low treatment intensity. Was that based on the proportion of households that were eligible households who received it, or was it just empirically? I'm just curious if you controlled that proportion. And the second was just the time scale, because you showed a really interesting, treatment effect that then reverted back to baseline. And just give us a sense for the time scale of that post delivery.
Let me do that one first, and then I'll tell you more about the design. But back to the time frame. This is the main thing.
Basically. Curious about the
here. Is this on years? So the post transfer. So this is the pre-transfer is 2011 to 2014. The transfers went out 2015 to 2017. And then the post-transfer is 2018 to 2021. So it actually includes the COVID period. Because we have such detailed data on the timing of births, you actually see that there's infant mortality is declining a bit in 2019 and 2020. And then in March 2020, it just spikes up, which others have documented in African settings with lockdowns and other things. So that's why you don't see kind of a downward trend. You might say, over time, infant mortality has been improving. Even in the cash period in the control group, one of these years was a drought year. And so, in that year, there was just really high infant mortality everywhere. There's still a big gap between treatment and control, but they both go up. So, you might be looking to see the red line is going up a little bit. That's weird. But there was a shock in the cash transfer period, and there was a shock in the post-transfer period. On the design, the proportion is in the high treatment areas, 2/3 of eligible households get cash, and in the low treatment areas, 1/3 of eligible poor households get cash. And so that proportion is randomized. We do control in the analysis, though, for the share of the poor in those areas. Strictly speaking, you don't have to, but you get more precise estimates if you do. So we do control for that, and then you can kind of see why. Like that's going to soak up some variation that's useful for that. Does that answer your question?
I can pick 2/3 and 1/3. I'm curious.
How did we pick it? Yeah, so that was less scientific. That was 10 years ago or whatever, 11 years ago. I think we did some rough power calculations on that. Maybe that was maybe we would have gotten different results with something different. Again, you're getting twice as much cash going in the high treatment areas as the control areas. So it's meaningful. But yeah, I would say that one is one of the less, I can't point to like some awesome code I wrote 12 years ago where we simulated power based on the, maybe we should have done that. I should have called you, actually. That's what I should have done. Yeah.
I'm thinking about the sustained economic benefits. Were you able to measure any improvements in like infrastructure or like housing improvements, like going to a metal roof, for instance, that may explain why you still can see some benefits over time?
There are, and so housing quality improves sustainably in the treatment areas, including things like roofing, floor improvements. Those are things that do improve. If we look at assets, even 10 years later, there's still significantly more assets in the treatment group. So people did accumulate over time. There's other economic changes. In the short run, there weren't too many new businesses formed in the short run in the first year or two, but once you get out to about 5 years, in the treatment areas, you see more business formation. So actually 10 years later, there's greater density of enterprises in the treatment areas. And out to 10 years, we start seeing more population in those areas. So our story, and we haven't written up the 10-year economic results yet, but the idea there, we think, is, there was this big boost of economic activity in these areas, businesses start being formed, and because there's more market activity, population kind of gets crowded into those areas.
Do you see shared infrastructure improvements too, like, water quality, things like that?
I forget the water ones. We have measured that. We don't see improvements in clinic infrastructure. We looked at that. So you might have thought maybe with more money going in, there would have been more investments in clinics. A lot of the clinic investments is coming from the central government. And so we don't see changes there. Yeah.
Did you measure mortality and morbidity?
So maternal mortality, we're still underpowered for, thankfully, in the sense that it's sufficiently rare that we still can't. Yeah, it's like an order of magnitude less common than this. We don't have a great direct measure, and it's really an oversight, but we have an indirect measure because we have household rosters across all these survey rounds, and we ask about previous household members, and we know which of them had children. So if over those 2 or 3 years there was a woman who had a child who had died, we could guess it might be related to a proxy for maternal mortality, but we don't have a great measure. We're fundraising to go back in the field to get maternal mortality measures and all-cause mortality for all adults in the area. Because another question is, well, maybe child mortality falls, but maybe other types of mortality fall. But that's something that we're planning for the next, the fourth follow-up. But we don't have good data on it right now. To your question. Yeah.
Sorry if I missed this, but I know they're free to spend the cash on anything. Were there any results collected on what they were spending it on? Or?
Yeah, and really the kind of first economic paper details as best we can what it is. A big share goes to food, which again isn't surprising given how poor the households are. So there are big increases in food consumption, and also basic needs, things like food, school fees or school spending. And then there's some purchases of like durable assets, and it's really hard to know if those are productive assets or they're just ways to accumulate. Even if you think of something like a cow, it's a productive asset, but it's also a way to accumulate wealth. So there's a bunch spent on those assets, roofing improvement. So we kind of detail that, but because different households make different choices because they're free to choose, you see a big thing. But I would say the most consistent was like big increases in food spending.
I think it could inform like what national funds do go towards if those are the things really.
Yeah, that's right. Yeah.
I was also wondering about, did you get any data on fertility and family planning? Like, what are the family sizes afterward? And are they having the family sizes they want? And
yeah, so we do. And I didn't bring it up, but it's a great question. And kind of in the fuller paper, it's obviously important because if the composition of births or fertility is changing, it could affect things. So during this cash transfer period, there's a transient and kind of modest increase in fertility among households getting cash.
Yeah.
So it increases 9 or 10% just for that year or two. and then it kind of goes, then they kind of converge again. So there is this transient increase. We were a little concerned, like, what if there's just like a very different composition of births, like very different women are giving birth, very different types of households are giving birth. So we actually can look at their characteristics. You know, what are the characteristics of those giving birth in different periods? And they look very similar. So it doesn't look like very different, like much richer people or more educated people are giving birth in this period. They kind of look the same. The other issue for estimation related to your question on fertility is, did people decide to have a kid after they got the cash transfer? And so could it be kind of a response to getting the cash transfer? So one of the analyses we do in the paper is we look at only people who were already pregnant when the cash transfer was announced, and you get exactly the same treatment. That was, from an estimation point of view, we're like, oh, you know, very different people are giving birth, and they're giving birth in response to the cash.
Yeah.
They could kind of bias the estimates, but we have this group that was already pregnant. So we probably spent like 40% of our time on this paper dealing with fertility issues because we were so kind of concerned about what would it mean for the statistical analysis. So thanks for that question.
There's two more questions here from the Zoom audience. One is, are there any long-term monitoring plans in place for the children who were born during the study period? Curious about more long-term outcomes among that group.
Yeah, so with our kind of like last bits of funding that we have, because again, we're in a kind of fundraising mode now, we are currently collecting data on exactly the kids born in the cash transfer period in treatment and control. And now they're 10, or they're like 8 to 11 or something, you know? And we are measuring anthropometric outcomes, cognitive outcomes. There's a whole battery of kind of academic-oriented outcomes in terms of reading in Swahili, math ability, and then other more fundamental cognitive measurement around, you know, executive functioning, et cetera. So I had worked with some of that data on another project, and we've adapted it to this setting, working with experts in that area. And we also have information on parenting practices. So we have a companion survey with the parents on discipline approaches and aspirations for your children. And so we'll see what we find. Like, are these kids' trajectories going to be different because they're in households that have more money? We're very curious about that.
And I should actually also mention that several people said inspiring talk, which I'm
very much.
One more last question. What is the difference between a cash transfer and minimal income, and what are the pros and cons of each?
Very quickly, because I see we're right at time. The kind of like basic income that people talk about, universal basic income, is quite different. Like the model of universal basic income very often it's universal, everybody gets it, and it's kind of, I think even maybe more importantly, it's ongoing. So the idea is like everybody gets $1,000 a month, and that provides some sort of floor. This was a one-time, transfer, very much targeted to the poor. So a different model. That said, if you're, raising incomes, maybe you get some similar effects, but we can't speak directly to this design, and I don't want to extrapolate beyond this design too much.
Thank you very much.
Thank you.